Hi, everybody, and thank you so much for joining us today on the Permobil Whitepaper webinar. And today we're going to be talking about a summary of the evidence on power standing wheelchairs, which is an update for 2023. My name is Janet Bernstein. I'm a physical therapist, and my role at Permobil is the Clinical Affairs Manager working within research and development, and I'm on the Scientific and Medical Affairs group, and my colleague will now introduce herself.
Thanks, Janet. My name is Carla Noyam. I have a PhD in rehabilitation medicine, and I work together with Janet in the same group of scientific and medical affairs as a senior researcher.
Great. We're both happy to have you all here. And Carla will go ahead and we'll see you in just a little bit. I'll get us started here. Our agenda for today is to start off with what's new in this paper for 2023. We'll talk about all the components that went into creating this paper. Then we have some exciting motion capture data to share with you. And then Carla will start to talk about the existing evidence based on a systematic review as well as the results of a survey. And then our clinical team will wrap it up with some clinical takeaways. We want to be sure to recognize additional team members that assisted us. We had global representation from our clinical education teams, as well as Anne-Marie from Scientific and Medical Affairs, and Paula, who is one of our biomechanical engineers, and our marketing team members. So let's first talk about what is a white paper. So a white paper traditionally is focused on a single topic, and it's intended to be concise and solve a problem. For example, in the medical field, this might be on one single new medication. The aim of this white paper is to discuss and describe the impact of power standing wheelchairs on an individual's life, as well as connect the peer-reviewed literature to the lived experience. And of course, we need to remind you and just put a disclaimer that this is not intended to be a substitute for the advice of an appropriately qualified or licensed physician, clinician, or any healthcare provider. So here are a few things that you will see new for 2023. The amount of available literature on power standing wheelchairs has increased since we wrote our previous paper. So we decided to really focus on power standing wheelchairs for as much as we could for every topic that you'll hear about in this paper. So we have also included more information about what both the research says and what our survey results were for how long and how often a person should use their standing wheelchair, or how long or how often they should stand in general. And then we're going to talk about some of the exciting results that we received from the survey that was completed by individuals who use a power wheelchair in their everyday lives. You'll hear from our clinical education team about some of the aspects of the in-depth interviews. And I mentioned that motion capture information, and that information is what we call preclinical evidence. And I'll explain why, but that's the purpose of that motion capture lab data, is so that we could understand how the body moves within the wheelchair when standing. So, as you can see, because this is a Permobil white paper, we've added a little bit extra to just a single, solution, but we hope that it helps to really provide you with a great resource. So now I'll let you know what stayed the same from our previous white paper. The one thing is that determining the best type of equipment for an individual should definitely be a team approach. That has stayed the same. Also, that there are no specific contraindications to the use of power standing wheelchairs. There are, however, some precautions related to joint contractures. So if someone you're working with has limited range of motion, you'll want to read that section in detail. And then the fact that while there is existing evidence for supported standing devices, that information does still apply to power standing, but we just chose to specify the device whenever we were able to. And then finally, similarly to the previous paper, we did take a global approach to writing this paper. So that is why you will not see information specific to funding in your region, but you'll hear from our clinical education team on how you can apply this to some of your funding procedures and reimbursement procedures in your area. So how did we get to all this information included in the white paper? So the first thing that was completed was a systematic review using PubMed and Medline without any time restriction. We use what's called the PICO framework, which looks at the population, the intervention, the control, and the outcomes. And this literature included was current as of March 2023 when we began writing the paper. We used at first, we used kind of a larger topic for the intervention, which was to look at any type of supportive standing, and we got quite a lot of information, 519 studies. So then we took the approach that to make this a little different, we used the 10 studies that were specific to power standing. And then we had a really interesting survey that was completed, and this was completed by individuals who used a Permobil F5 VS and agreed to be contacted by activating the My Permobil app. We had a total of 137 individuals who both used a power standing wheelchair and completed at least 40% of the survey. We used quantitative and qualitative data points. And then those that were under 18, we did have them fill out the survey, but we screened out any potential sensitive topics. And then, as I mentioned before, we had our 3 in-depth interviews based on the criteria that was provided in the interview guide based on the ICF framework, looking at the body, looking at function, looking at participation. And then we tried to tie that back with some of the keywords that were listed in the evidence. So I said we would start talking about the motion capture lab data. And this was really quite interesting way to understand how someone moves, or what we call displacement, when they move from sit to stand and then back to sit. This motion capture data allows us to track movement and record it in a 3D manner by using reflective markers that are placed both on the wheelchair and on the body at specific bony prominences. And then that data is captured by a series of cameras. You can see there with the pink circles around them, and analyzed through specialized software. You have to say that the subject that we used in this data is non-disabled, and that's why we call it preclinical data. So, the reason we did this is because depending on what type of supportive standing device a person uses, sometimes transitioning from sit to stand and back to sit can be occasionally a concern over how these movements can impact skin integrity and possibly even positioning. For skin integrity, this is related to the potential for sliding between the body, seat, and back support, which may cause shear displacement. During sit to stand, shear forces are also generated on the seat and back support, according to Cho et al. And colleagues. Although there is technology in many power mobility devices to reduce the shear from occurring, some of these skin concerns still may remain. Regarding positioning, it may be a concern of yours that an individual would lose their positioning in the wheelchair when they return back to a sitting position. But what we wanted to look at is how much displacement or movement that actually happens. So that might be a concern if someone's driving with a head control or head array, or maybe they can't reach their joystick, especially if when they return to sit, they're not able to reposition themselves. So for the results of this preclinical data, we saw some really interesting information about the displacement between the person and the wheelchair. And we really saw very limited movement. So if you're able to see the color on the squares that we're being shown on the screen right now, the red squares is where the body was originally positioned. Green indicates where those markers were as the person went into standing in the wheelchair. And then the blue squares represent where the person was seated after they completed this standing routine. So even though this was a non-disabled person, the chair was set up and programmed to his specifications and had all the safety and positioning components in place. So what are the results? So the location with the most movement was the iliac crest, so the top of the hip bone, as you can see from the side view. And it moved only 16 millimeters. For those in the States, that's 0.63 inches. So for the rest of the body markers, displacement was actually less than 10 millimeters or 0.4 inches. One other example that we chose to select to analyze is the position of the head, since we know that that can be critical both for support and function. What we found is that the forehead moved 7.8 millimeters or 0.3 inches down and 3.4 millimeters or 0.1 inches back. And what we thought we could take away from that is that there's potential that the cervical spine, the neck was actually, and head was actually able to maintain its resting point, or we could even say possibly the normal curvature that a person has once they return back to sitting. And so while we can't generalize this to everybody that uses a power wheelchair, it just might help to provide some insight in the fact that we really don't change position all that much when we go from sit to stand back to sit. So now we will highlight a little bit of information on how long and how often somebody should stand in their power standing device. And what we can fall back on for this, because there is limited data for power chairs, is any supportive standing device. So primarily Peleg and Livingstone describe that the amount of time and duration really depends on the goal of the standing activity. So if someone is more focused on mental health and their bone health, it's recommended to stand for 60 minutes, 4 to 5 times per week. And then if there's more of a focus on self-care, balance, range of motion, spasticity, skin, the recommendation is to stand for 40 minutes, 5 times per week. And then there is a study by Young and colleagues who focused on one specific diagnosis of Duchenne muscular dystrophy, where they actually indicated that an individual should stand 60 minutes, 4 to 5 days per week, and avoid periods where you do not stand for longer than 4 weeks at a time. So let's look at what our standing duration and frequency said for our survey. So we asked individuals, how were you instructed to use your power standing wheelchair? And we had 38% tell us that they were instructed to just stand as they could tolerate it with no specific time or duration or frequency. We had 23% who said they were told to stand for a specific time per day, but that ranged anywhere from 12 minutes to 180 minutes or more per day. And then we had 20% of responses that talked about how they were instructed to perform standing for pressure management, and 11% that were instructed to just stand when they had to do a functional activity. The other thing that we looked at is how frequent someone stood per week. And you can see the results there. 42% reported that they used their standing function every day. 31% said that they used it at least 2 times per week, but not every day. And then we did have 17% who used a few times per month, and 9% did not use it at all. And Carla will get to some of those considerations in just a moment. And this is where you can see how we kind of divided up the duration of time that someone was standing. And this will come into play as Carla goes into our data points that are connected to each outcome, because we wanted to really think about the total amount of time that someone stands and maybe what that could indicate that they're standing for. So when you see some of the results, you'll see that we divided our individual survey participants into 3 categories based on their frequency that they stood. So our high frequency users or high frequency group are those who reported standing more than 30 minutes a day for more than 2 days a week. The middle frequency would be 16 to 30 minutes a day, more than 2 days a week. And low frequency is less than 15 minutes per day. And one last thing to consider before Carla joins us again is that there is information emerging about the differences between standing in a power mobility device really related to independence compared to a non-powered standing device. We've seen mostly fewer limitations in daily usage. So standing with a power wheelchair provides the individual the ability to control the decision on when they want to stand, and ultimately makes them more independent and have less restrictions in daily use. And then it's also possible that it can eliminate the amount of transfers, which can not only benefit the individual, but possibly also the caregiver. And we have 2 quotes here from our qualitative survey results, where one individual says that my standing wheelchair is more convenient because I don't have to transfer to stand, which results in more standing. So pretty consistent with what the literature is showing us. And then another gentleman says, I have ALS and standing is important to my health and reduces the load on my caregiver. So I will now turn it over to Carla to give you a more detailed overview of the literature.
Thank you very much, Janet. That was a great introduction. We will hop right into the overview here of the evidence that for this white paper update, we have actually structured within the ICF model. And the model you can see here on the sheet. So we have different boxes that consider the whole perspective of someone's life. So we have body functions and structures, activities, participation. There on the top we have quality of life and independence, and on the bottom there we have personal factors and environmental factors. And we go over these boxes one by one. And as you can see here as well, is that the different outcome measures are listed in each of the boxes and they are color-coded. So for the color coding, we consider the amount, the type, and the quality of evidence available. And then we have rated them into higher quality, which is green, lower quality, which is blue, limited evidence in purple, conflicted evidence there in orange, and in black we have the product and user characteristics. So we got to this grouping by considering the different levels of evidence, and as said, as Janet also explained earlier, The highest level of evidence we consider to be from our power standing literature. So we had in total 10 studies reporting on power standing, and these were considered the highest level. And then we had additional publications from standing on other devices, as well as our survey, that were considered as supporting sources of evidence. If we then continue to looking into the first box of body functions and structures, there we go. So there is highlighted in pink. That's where we're going to start, body functions and structures. And if we go to the next slide, there we will start with our first outcome with higher quality evidence, which is pressure redistribution. So we concluded that power standing enables pressure redistribution. There is no direct evidence to show that power standing reduces the risk of pressure injuries. However, we see that power standing leads to significant offloading and pressure redistribution, and thereby decreases the risk of pressure injuries. So this significant offloading is both on the seat and on the backrest, and this is something unique to standing, that compared to tilt and recline, standing is the only power function that can decrease the loads of the seat and the backrest simultaneously. And Janet already mentioned also already in her introduction there with the motion capture analysis, that shear forces are to be considered as well, and in particular, of course, when we talk about pressure injuries. So something that requires attention when we talk about how the body might slide with respect to the wheelchair, and that this needs to be carefully monitored. Our next outcome measure is bladder and bowel function. So the literature shows that power standing may improve bladder and bowel function. One study in those with cerebral palsy, multiple sclerosis, and spinal cord injury showed that those reporting on constipation had improvements on an outcome measure called the constipation quality of life scale. And one of the aspects that was in particularly also mentioned was that it was easier to pass gas. A second study showed that there were improvements in self-reported digestion. This was done by parents of those with Duchenne muscular dystrophy. And the third study reported from chart review, so looking into medical documentation of those that had were provided a power standing wheelchair, and showed that after the provision there were less urinary tract infections. So that was also a really interesting result. Our third outcome there with higher quality evidence is an increase in range of motion and muscle length. So one study showed that there was an increased passive range of motion of the lower limbs. This was measured by a clinician, and again, this was the same study on a mix of individuals with different diagnoses with cerebral palsy, multiple sclerosis, and spinal cord injury. Study in those with Duchenne muscular dystrophy showed that there was an increased hip and knee flexor muscle length. And the third study, also on individuals with Duchenne muscular dystrophy, used video analysis to show if there was an increase in range of motion, and they showed no differences. And here, one also has to consider for some of these outcomes, right? You cannot maybe always expect an improvement, as with progressive diseases and studies running over longer periods of time, maintenance could also be a really good outcome. Then we will move on to the outcomes with lower quality of evidence. And the first one there is that there were indications that power standing promotes bone health. So it was shown that weight bearing with a power wheelchair is around 75% of the body weight, and this is comparable to what has been seen also in those with other standing devices, such as a standing frame. One clinical trial in 4 individuals with Duchenne muscular dystrophy showed that 3 of them had a stable bone mineral density after 1 year, and 1 participant decreased in their lumbar bone mineral density. So overall, it was a small group, but we see 3 of them are stable, and 1 of them had maybe unexpected result there of a decrease in the lumbar bone mineral density. And the last studies here to mention, as how there was actually not so much on power standing wheelchairs specifically from the clinical trials, but here we can use the systematic reviews on other standing devices also as a support, pointing also towards the direction that standing can indeed promote bone health. The second outcome measure here is spasticity. So there were also indications that power standing may decrease spasticity in the lower extremities. Unfortunately, there were no studies on power standing at all. But again, some really good systematic reviews on other standing devices, summarizing all the available literature, showing weak evidence, but all pointing in the direction that standing does have this potential to decrease spasticity. And the last outcome here is mental health, with indications that power standing may have a positive effect on mental health, seen by positive mood, reduced hyperactivity, increased confidence and self-esteem. Parents in particular reported that their children were happier and more content, more mature, and also described fewer periods of grumpiness, frustration, and anger. On the other hand, it was also noted that some individuals, they were very self-conscious when they were standing in front of others, and they did not really like to be the center of attention. And in one study, one individual actually stopped participating in the study for this reason. So this is definitely something also to consider and to discuss when a journey in standing is being started. From the 4 trials reporting on pain, there were 2 trials reporting on a favorable effect, which could either be that participants did not have pain at all, or they even experienced a reduction in pain after standing. And 2 trials also reported on unfavorable effects of pain. And the locations of this pain were really varied. So in the lower extremities, ankles, knees, legs, feet, but also in the back. It was also noted that if not causing pain, power standing may actually provide the opportunity to independently manage pain and comfort by standing. So related to what Janet also was indicating before, how to be able to adjust your position when you want, and even adjust your power standing position while standing. So then there was a whole list of outcomes with limited evidence. So you see, it's a long list, and we took a really broad approach just to see is there anything out there, and then unfortunately there was not so much evidence available in the literature. We also have asked for the impact of these outcomes in our survey, so we have some results from that you are very welcome to read in our white paper, but we will be too much to go all over that today, but just to say that there is even more potential than the outcomes that we have already covered today. So the first survey result I would like to present is on pain. So we see that 54% reported on a relief in pain after standing, and 11% actually mentioned that standing caused pain. And the rest of the participants said that it had no impact on pain. If we then asked those participants that reported on relieved pain, so that was about half of the participants, what kind of pain that was, two-thirds of them reported that it was orthopedic pain, so related to the bones and the muscle and the joints, and 1/3 on neurological pain, so more of this burning and tingling pain. The second thing that we've done there then is looked at, is there a dose-response relationship with regards to the impact of power standing on pain? So do we see that those that stand more frequently have more pain, or the other way around? And those results are presented here in the lower graph. And Janet has presented these groups before. So we have 3 groups: those that stand most frequent, the high frequency group, we have a middle frequency group, and a low frequency group. And there we see that of the high frequency group, there are only a very limited amount of people that have actually experienced pain. Then in the middle frequency group, this percentage is slightly higher. So in the low frequency group, we see that it was 27% that had an unfavorable impact on pain. So they said that standing actually leads to pain. So, so then the question is, of course, what is the chicken and what is the egg? So do people who stand more frequently, do they do that because they do not have any pain? Or is it possible with more frequent standing that you are able to relieve your pain? We cannot really tell that from these results, but it would be really something interesting to dig into further. Another survey result I would like to present to you is fatigue. And fatigue was actually an outcome that was listed as we have seen very little reporting on in the literature. So here our survey adds some of these results, and we see that about half of those with fatigue report that power standing has a favorable impact on fatigue. And again, here we looked whether people in these different frequency groups, so the high, the middle versus the low frequency group, had different experienced different impacts on their pain. And what we see is that those who stand most frequent and least frequent have participants with an unfavorable impact on fatigue, right? In the upper graph there you see around 11% that report on an unfavorable impact in red. And in the low frequency group, it's around 15%. They're in red, reporting on unfavorable effect of standing on pain. But there's no unfavorable effect mentioned by anyone in the middle frequency group. So that's interesting, right? So if we just speculate, so those in the high frequency group, do they also get tired because they stand a lot? Those in the low frequency group, are they too tired to stand more often? And those in the middle frequency group, are they very good at their fatigue management and they know their body very well, so they can choose the exactly right dosage there for them? Alrighty, then we covered all the body functions and structures, and we will continue to the next box, which are the activities. So we see in the literature clearly that power standing enhances independent activities of daily living, personal and medical care, and leisure activities. There were improvements in a wide range of activities, including cleaning, working out, turning on water in the sink. Really, a lot of different activities were mentioned. So as for personal and medical care activities, the most discussed topic was urination, so males passing urine and their independent toileting that was allowed by power standing, so they could toilet without go to the toilet without making a transfer, and they were also fast red toileting, which was seen as a really important, meaningful benefit. So the second box there is that power standing increases functional reach. So simply it increases the ability to reach on shelves and cabinets and on counters, and this is very nicely presented on the picture there, where you can see that it allows to access those higher shelves in the grocery store. And the third box is around communication. So power standing facilitates communication in different ways. So you'll be able to have face-to-face communication, which was mentioned in different studies. Better hearing by being on the same level, see more clearly, have a better overview, and cope also better with crowded situations. Then in our survey, we also asked what type of activities or tasks do you typically do when standing in your power wheelchair? And we see there that the most common activity that was mentioned was pressure management. So 117 people answered this question, and we see that 65% of them actually noted that this is an activity that they do in their power standing wheelchair. Other common activities were socializing, training and exercise, and then we get into the more functional activities such as chores and mobility outdoors, and the community activities. You also see another result there a little bit lower down the graph, and those included activities such as cooking and other kitchen activities, walking the dog, and sexual activities. So then we have ticked the box of activities, and we go to the box of participation. So here our first result is that power standing can be beneficial in social work and educational settings. We see that there is an increased satisfaction with meaningful self-identified participation outcomes. It was helpful for teaching and ceremonial activities at school, and faster toileting, as we just discussed, means less time missed from class as well. So it benefits in multiple ways. And then we've seen that it's beneficial at work for social participation and participation in physical activities. And some examples are being able to go to restaurants with high top tables and participating in a chemistry lab. So in our survey, we also asked if power standing allowed to participate in new opportunities. And here we see that more than half note that power standing allowed for new opportunities. So in particular, this was further surveyed for work and for schools. So for work, it was noted that there was an increased opportunity for employment, more specifically the roles that you can take on or the places you can apply to, as well as increasing the work hours that you want to work. And examples here were, for example, being able to be a teacher because you have access to the smart board. And at school, it was an increased ability to participate in class discussion and in more school-based activities. Then we have covered participation, and we will continue with quality of life and independence. First of all, independence. So the research clearly shows that power standing may have a positive impact on independence. So both quantitative and qualitative findings support a higher level of independence, and related to the large range of activities and participation, as we have discussed before, and these functional abilities associated with standing, these are related also to the enhancement of the independence, and particularly also with the control over the decision on when to stand in the power standing wheelchair. The next outcome then is quality of life. So unfortunately, there was very limited evidence for the impact of power standing on quality of life. There was in fact only one study that looked on power standing and quality of life, and this study found very varied results both within and between the persons participating. However, we also asked about quality of life in our survey. And we particularly asked here to compare their quality of life with standing function compared to without power function. And here we see that 80% of the people, so I think this is a very powerful number, 80% of the people participating in the survey reported that quality of life is higher with the standing function compared to without. So this is a great addition to what we've seen in the literature, and hopefully a reason for the researchers listening in here to explore this also further in future studies. Alrighty, the last thing that we then are about to cover is the personal factors and the environmental factors. So we have listed multiple ones there. Of course, we have limited time today, so we have picked two, which is age as a personal factor there. And with regards to the literature on power standing, we actually see that most studies focused on children and adolescents. Our survey, on the other hand, was a really large majority of adults, and therefore kind of support these findings really nicely of what is seen in the literature, and we see that the results are really complementary there and show the same directions. For body functions and structures, we of course have also the additional support from literature on the other standing devices. So with regards to activities, participation, independence, and quality of life, we do not expect large differences, except of course for very different types of activity and participation needs between the younger and the older population. The environmental factor that we wanted to highlight here is the size of the wheelchair base that is noted in different studies as a barrier for power standing. So it was noted by adults who had adapted their homes, had experience with another wheelchair before, and noted that the base was larger and therefore had more trouble doing their routines in the same way as they were used to. And for children, the base of a power standing wheelchair is also mentioned to be relatively large compared to the average pediatric power wheelchair. On the other hand, we've seen in our qualitative survey results also that integrated power standing function means less equipment in the home and while traveling. So there's always multiple sides to it. Alrighty, then we have ticked all our boxes in the ICF model, and I will hand over the word to Janet again.
Thank you, Carla, for all of that great information. We can see it's quite extensive and applies to many different aspects of an individual's life. So now we will hear from a member of our clinical education team to talk us through the variety of ways that you can apply this white paper to clinical practice.
Thank you, Jonathan and Carla, on that. I know that I certainly learnt a lot from reading the white paper. Now we're going to jump into the clinical application. So we've got this white paper. What are we actually going to do with it, and how is it going to impact our practice as clinicians? Next slide, please, Janet. For those of you who don't know me, my name is Tilly. I'm one of the clinical services team members in Permobil, based in Asia Pacific, and I'm an occupational therapist. Next slide, please, Janet. So when applying the evidence-based approach in your practice, you really need to consider to integrate the three different components in your practice and also your interventions. As we can see on this slide, you know, we've got the client perspective, which includes their personal, social, cultural values and their own specific priorities, preferences and expectations. And it also includes the perspectives of their family and caregivers, which is also really important. Your clinical expertise and capabilities for making clinical decisions with the best possible judgment, with the knowledge and the experience you've obtained from your education, training, your experience and your professional interaction also plays a key role. A good therapist will likely not become a great therapist if we don't challenge ourselves and our competencies. This in turn is going to help broaden our perspectives and, really prevent that tunnel vision from occurring. We don't want to get stuck in our ways. We want to be better therapists every time we go out there and work with someone. The third part is, the research evidence and clinical practice guidelines. These can provide information from scientific literature, publications produced by researchers, subject matter experts or groups, and clinicians to provide new insights into, general practice or particular interventions. This is why it's so important that, when we are working with someone, we are making sure that we're combining all three parts of this evidence practice model to ensure we are delivering the best intervention we can. And, evidence-based practice is really important. And, we want to make sure that this white paper is helping you with your evidence-based practice. In this document, you can find the outcomes that we've described in the literature, and it can help align expectations of what is possible, but we don't want it to set boundaries. As we've discussed so far, there's room for further research and evidence over the coming years. So we would really encourage you to use this paper to extend your knowledge, extend your practice, extend your questioning, so that we can really make sure we're trying to cover every base of that ICF model. Next slide, please, Jeneth. So what does this actually mean for you? Well, yep, absolutely. It's going to improve your evidence-based practice. We really hope it can expand your knowledge within the specific domain of power standing wheelchairs, and to really build on your current knowledge. We want to help you come up to speed on the latest literature. If you do want to read more about a certain publication, the references there, you can go out and read up on that specific one further as well. It can really help support your justification to prescribe a power standing chair. It can also help you provide evidence to the wider team member. Why are you asking them to come along? Why are you asking them for additional information? It can also help when you're talking to funding bodies and authorities about the importance of power stands, help encourage, additional conversations, and to really help align everyone's expectations and outcomes too. For the right end user, you may also decide to share this document with them also. Next slide, please, Jeneth. So in regards to a power standing wheelchair, what does being involved for someone actually look like? Well, participation can look as simple as, the setting or environment which an individual wants to use the equipment. This could be at home, work, school, within another education setting, or a social situation. And most importantly, this is going to look different for every individual. No two people with the same diagnosis are ever going to be the same. Life roles of that individual may dictate the levels at which someone needs to access their laundry perhaps, or to prepare meals for themselves and their family. It's also really important to consider who that individual is, what their roles are, and more specifically, what their goals are. So at home, we might look at their PADLs or their ADLs, their roles and responsibility. And, this may also really differ for someone living in an urban environment versus a rural, or kind of someone living in a, out in the bush type thing. Within someone's work environment, we need to look at how are they participating within their whole work environment. Don't just look at their desk if they have an office-based job. Make sure that you're looking at the lunchroom, the meeting rooms, all those other places they socialise too. Also don't look at what just their current role is, but what is their potential future role? Are they working only part-time because of current barrier in place? Can we help overcome that further? In regards to an education setting, this could be at their school, TAFE, university, or many other places. Make sure we're looking at the classroom. but also the settings outside of that person's main classroom. What about, you know, for that child at school, make sure you're looking at the canteen, the library, the oval. You know, if they're spending lots of time in physical education, well, make sure you check how wet does that oval actually get? Is it accessible? Is it not accessible? Where are they going? What excursions and other outings are they going on? And finally, social settings. You know, this is going to be vast and so different from everybody. You know, make sure you're looking at their direct circle, throughout their family, their friends, their wider community. And I also like to dig here out, what are the things they currently not doing that perhaps they used to do or would like to do? And what are those barriers? And across all of these elements, I really encourage you all to really, you know, ask them, well, what aren't you doing? What would you like to be doing? Or what could you be doing better? What barriers are in place? You know, through appropriate AT, we're really lucky, I think, in the job that we do. We can really enable people to return to those really important tasks and participation aspects that they really want to be doing that perhaps they're finding really difficult or unable to do. Next slide, please, Jenna. You know, when I was first told about the butt perspective, or the bottom perspective, whatever you want to call it, it really stuck to me, and it just made the whole, you know, made it really functional and a really black and white concept. And, you know, providing a person with the ability to stand in a power wheelchair changes their view. You know, when I first heard you saying, well, if I'm sitting here, I'm constantly looking at people's butts. So by giving someone the ability to stand, instead of looking at bottoms, they're able to look at people in the eye, just as you and I who can stand also do. And providing a piece of appropriate AT equipment, we can create the opportunity for a person to not just be at an event. So, you know, not just going to an event to be part of it, but actually being in the event, which means that they're truly participating at the time. For example, not just going to the basketball game and sitting on the sidelines, perhaps, you know, with the appropriate prescription of a great wheelchair or standing wheelchair, they're now able to actually shoot some hoops or be an active coach from the sidelines. You know, for at school, it's not just about, you know, getting someone to write their part of the project up on the board. Being able to stand means that they can do it. Their emotions can be reflected in, you know, how they write that message and that sort of thing. And, you know, the example that we've got on this slide as well is about a user out of Belgium, I believe she is, and she said the first time she had a power standing wheelchair after 20 years, she went to the same New Year's Eve party, and this for her was when she lost that butt perspective. You know, she said that through stand she was able to look everyone in the eye. She was able to really find, okay, oh yes, that's who I want to go talk to. But equally, like, you know, I'd go to a party, may not want to talk to someone. So she was able to avoid that person for whatever reason, or, you know, talk to them later throughout the night. So for her, that was such a game changer about being able to actively participate fully at that New Year's Eve party. Next slide, please, Jenna. And you know, what was really interesting about the surveys was there were a couple of key take homes for me, and that, you know, ultimately the benefit of power standing is that it provides individual with autonomy and choice and control. It provides the choice and the ability to participate in whatever that person chooses to do or not do. You know, this common theme really supports best practice in that the client is an expert on themselves and their environment. Power standing can enable the individual to engage in a manner that they want to. Standing can enable the person to navigate their environment and participate in the manner that they want to. They can be part of the event, not just at the event. Standing allows the individual to lose the butt effect, as we've discussed, but ultimately power standing allows, you know, the client to expand their horizons and options and help them overcome those barriers and difficulties. Often providing power standing mobility you know, it's really going to allow that person to exactly what they do. And I would really encourage, when you're reading that white paper, don't skip over, you know, the quotes we've pulled out of the interviews in the survey, because it will really enable you to reflect on, okay, this person's currently has this power standing chair, and are there some similarities to the person I'm currently working with? What else could we think of outside of the box, and what are the other opportunities that this power standing chair could give this person? Next slide, please, Jenna. And what's really clear is that it's not about the dosage. So by this, I mean, it's not about the benefits of the body functions and structures. We're not really prescribing this chair for those medical elements. All those things are a beautiful outcome that come about from function, okay? So that, I mean, like tone management, spasticity, range of motion. You know, as was discussed earlier, is that we do know that people are prescribed to stand for different amounts of times for different outcomes, specifically in regards to body functions and structure. So, you know, a dosage of 40 minutes 5 times a week has been proposed to have a positive impact for outcomes such as self-care, standing balance, range of movement, cardiorespiratory strength, spasticity, pain, etc. While 60 minutes 4 to 6 times a week has been proposed for an impact of bone and mental health. And for individuals with Duchenne's muscular dystrophy, it was recommended that a power standing chair be used for 60 minutes 4 to 5 times a day. But as we were seeing from the survey, you know, over half of the participants in the survey had been clinical recommendations for duration of standing, but this ranged, you know, anywhere from 12 minutes a day all the way up to more than 2 hours a day. So ultimately, it really demonstrates that there's not yet a clear clinical consensus of how much is required for a clinical benefit. But what the survey and interviews have shown us is that standing has a positive impact on function, and how much someone is going to stand is going to be determined by function and participation. And again, it's coming back to that autonomy of control. By giving the person a choice to stand and achieve their goals, ultimately is what that, you know, that true clinical reasoning prescription is about. So first and foremost, when we're prescribing a chair, keeping that function in mind, you know, how are we going to enable that person to increase their participation for their ADLs? How are we going to increase participation for their meaningful activities? And how is this chair going to contribute to their overall quality of life? As the role of a clinician, our role is to really help that person identify their goals and make sure that this piece of AT is going to meet their goals and work within their environment. We've also got to be aware and discuss potential secondary complications, and where possible, we need to start standing as early as possible so it really becomes part of that habit. Next slide, please. Some key take-home learnings was, for me, 2 main ones. Firstly, throughout the interviews, I was absolutely overwhelmed by the impact that power standing has on bladder and bowel function. But secondly, and most importantly, the theme of choice and control. You know, having that choice to complete a task independently, having a choice to be at eye level, choosing to cook a meal, choosing to write on the whiteboard, or choosing to complete a task or to remove themselves altogether. Finally, what the individual is not doing is also really important, okay? We need to focus on how can these chairs enable that increase in participation and function. Next slide, please, Jeneth. So I would really encourage you to, you know, have a look at this white paper and really see how it might contribute to your change in practice. The paper's really demonstrated that there's parallels between the evidence, the clinical experience, and self-reported outcomes. You know, there is a really great impact on quality of life, and power standing chairs can have a positive impact on independence and participation. Next slide, please, Jenna. So if you do have any questions, we would really encourage you to reach out to any of the team members, download that paper, have a read, and if we can be of use to help you apply this to your practice, we'd be more than happy to.
Thank you so much, Tilly. That was a great way to wrap up such an excellent paper that was written, as well as those clinical take-homes. We know that we are at time, but if you are able to stay for just a moment, we'll give you just a couple of announcements. There should be a link in your toolbar to download the PDF. If for some reason you're not seeing it or you can't access it, you will be receiving either a link to download or the PDF itself in the coming days. And we should also be able to provide you with a recording of the webinar in the coming days. I did want to address just 2 questions that came in. If you all are able to stay, we would welcome you, but if you need to hop off, we totally understand. One question was related to the motion capture data, and it was asked if the non-disabled person kind of allowed himself to remain in a relaxed position. And yes, we tried to encourage him to stay, to not reposition himself, just allow the chair to move him. Of course, that was just a simulation, but we did try our best to do that. And then we had one individual that asked a little bit more about how we determine the levels of evidence, and I will encourage you that there's an appendix within the white paper so that you can seek out, for those of you who are much more into the grading and the levels of evidence, you can definitely seek that out. And so I think we will go ahead and end it here. If you have any other questions, we'll be happy to address that as soon as we have completed the webinars. And thank you guys so much, and have a wonderful rest of your day. And we'll talk to you soon. Thank you.
Everyone.